Our next speaker for tonight is our very own Reverend Matthew Edelman, and he manages Norton Healthcare's program. He received a Master's of Divinity from the Southwestern Baptist Theological Seminary and became board certified with the Association of Professional Chaplains. Reverend Edelman also completed an ethics fellowship at the Fairbanks Center for Medical Ethics at the Indiana University of Health. And in 2016, Reverend Edelman brought in Norton Healthcare's first facility dog, Henry. I know Henry is very beloved. Henry became a full-fledged member of the pastoral care department. And ultimately, this really cool initiative grew into Norton's Heal Dog Health Program, which brings in specially trained facility dogs to provide therapeutic comfort to patients, families, and staff. Please join me in welcoming the Reverend Matthew Edelman.
Thank you. In the height of the pandemic, two brothers, I'll call them David and John, packed up their families and traveled to Texas, leaving the family farm upon which they all worked and lived to celebrate a wedding. Their luggage was a little lighter because of the absence of masks or hand sanitizer, because you see, they believed that despite the raging headlines around them, COVID was a hoax. Nevertheless, they had a wonderful weekend in Texas celebrating with family that they rarely saw. The wedding was elegant, the bride beautiful, and everyone whispered that the groom had clearly married above his station. On their last night together, they all gathered at a favorite local barbecue restaurant. And one would later remark that it didn't taste like barbecue. And in fact, it didn't taste. On the van ride home the next day, one family member complained of having a headache, another one of having the chills. David and John, who owned the family farm, also owned a cough. Nothing serious, just really annoying. When David and John were admitted to the ICU, they were met by a team of professionals with a reputation for looking beyond the chart to the patient before them. David arrived already on a ventilator, which was working harder and harder to keep him oxygenated. But in the course of time, it became clear that neither the vent nor any treatment was going to be enough to sustain his life. And so the decision was made to extubate him and allow him a peaceful, natural death. A nurse did her best to hold her phone steady so that David's family could say goodbye via FaceTime. John was just a few rooms down the hallway, and though he knew about his brother's passing, he was too sick to attend to it. The ICU team, knowing their story and knowing now that there was a grieving family on a farm outside of town with now only one adult male left to work it, turned their full attention to John, and it was a full court press to keep him off the vent. And yet, despite the treatments and the team meetings and all the consultations, his condition progressed inexorably toward intubation. And regretfully, the physician and the nurse came to John, and they explained to him all the measures that they had taken, all the interventions that they had done, and explained that they were very sorry to say that none of them had had the effect that they had hoped that they would, and that he really needed to be intubated if he had a chance of surviving. Between strangled breaths, John agreed to be placed on the ventilator. And as the vent was ready, the nurse informed John that she was going to lay the bed flat in preparation for the procedure. And so she pressed the button. And as the whir of the bed motor slowly reclined John. John looked across the room at the physician and in a gasping breath asked, "Hey, doc, does the government give you an extra $5,000 for doing this to me?" People who study these things say that morals developed when human beings figured out that living together and working cooperatively increased their chances of living exponentially versus walking the frozen tundra alone. And so societal rules were established that not only let us work cooperatively together, but also gave us an advantage over those things that wanted to kill us. The agreed upon rules for how we behave and interact with one another and how things should work have come to be called morals. Morals can be explicit, like, "Thou shalt not murder." Or morals can be implicit, like, "You should really give up your seat to an elderly person." And there's an expectation called reciprocal altruism, that so long as we all agree along the same moral framework of how we should behave and interact with each other and how things should work, that you won't interfere with my pursuit of living and I won't interfere with yours. And if you get enough people living and working together collaboratively in close proximity with the same agreed upon understanding of how we behave and interact with one another and how things should work, and that moral framework is reinforced over and over again through the generations until it becomes more than just a set of rules for how we should live. Morals become how we understand ourselves, how we understand our place in this world, our degree of trust in each other, and the foundational beliefs that we cling to when our life falls apart. What follows now is an overview of what happens when that framework is fractured by a traumatic event and the potential impairment of the subsequent moral injury. We're going to look at a recent model which attempts to place moral injury along a spectrum. And finally, we'll leave on a note of optimism, for we are not helpless in our efforts to mitigate the effects of moral injury. But let's begin. By the end of our time together today, I hope that you will understand at least some of the core concepts of moral injury. We're going to go over a few different definitions and look at how the idea of moral injury has evolved over the decades and see what has maybe been cast aside and what threads have endured. We're going to describe some of the symptomology around those who are experiencing moral injury. This could be a presentation in and of itself. So for our purposes today, we're just going to have a brief overview of it and articulate just some of the several effective means to mitigate moral injury. So to begin, in order to be morally injured, something has to happen. That something is called a potentially morally injurious event, or a PMIE. And sometimes I'll say the whole thing, and sometimes I'll just say PMIE. But a potentially morally injurious event often takes the form of a person or an organization that commits an act of cruelty or violence or fails to protect others from an act of cruelty or violence. With moral injury, you can be injured, you can suffer moral injury by learning about an event or witnessing an event, but you can also suffer moral injury by your own actions. In other words, you are the one who has perpetrated the violence or the act of cruelty, and now you are suffering from that, from your own actions. So that sense of agency becomes important with moral injury. And so, for example, a nurse is assaulted by a patient while providing routine care, and she feels she's being blamed for it. That nurse's trust that the organization will protect her has been betrayed. And so too has her trust in her leaders. She finds now that her own self-perception as a nurse has changed. Where once she might have stayed late and advocated for her patients, now she just wants to do her job and go home. Thank you very much. Her colleagues, too, witnessing how she's being treated by the organization, are experiencing the same feelings of betrayal of trust. And they don't have any trust in the organization or their leaders because they're just seeing what's going on. And yet we say these events are potentially morally injurious because morals are formed based on culture and context, how you were raised, and a multitude of other factors. And so an event which might be morally injurious to you may not have the same effect upon the person standing next to you. What makes it morally injurious will be the symptomatology of each individual post-event. In our introductory story with the ICU, we have the ICU staff that is working from a deeply held moral framework. Now, given that they've chosen healthcare as a career, we can assume that that moral framework includes such beliefs as a duty to protect the most vulnerable, to heal the sick, and a commitment to professional integrity. And David and John's actions violated all of those morals when they traveled without any kind of protection, without any due consideration of any vulnerable people that they might meet along the way. And when John questioned all of the efforts that they've made to save their lives and wondered if it was all about money. And look, if this were an isolated event, or even if it happened occasionally, one's moral framework would probably hold. But David and John are representations of countless potentially morally injurious events that healthcare workers experience daily. They are subtle, repeated hurts, often dismissed in the moment, but add up to traumatic injury. So how did moral injury as a concept begin? So for that, I need to take you back to Baltimore, Maryland in 1994. Dr. Jonathan Shea had a problem. He was a psychiatrist working in the VA with Vietnam veterans. Many of his patients were suffering from PTSD symptoms, and yet he realized that the symptoms that he was seeing in many of his patients didn't quite fit under the umbrella of PTSD, nor did they respond to the treatments he was providing that would normally help respond to PTSD. And so he came up with this term, moral injury. He said moral injury is a betrayal of what's right by someone in authority in a high-stakes situation. Now, Dr. Jonathan Shea was working in the VA with military veterans, and so he's thinking of moral injury in a military context. And often these stories of a betrayal of what's right by someone in authority was being told by, were stories of war brutality, right? Of things that should not have happened, but did. Orders that were given that should not have been given. And since 2009, efforts to define moral injury and expand upon the context to which it's applied have proliferated. And so I want to show you just two more examples of moral injury definition, the evolution of our understanding of the concept. So in 2018, this definition came out that greatly expands on moral injury and highlights that moral injury is a type of trauma. It's a trauma experienced by the impact of moral transgressions and ethical standards. The middle part, letter I, borrows a lot of what you saw from how a PMIE was defined. That's just act perpetrated or witnessed or learned about. And the latter section, the II, borrows from Dr. Jonathan Shea the feelings of betrayal, but adds the words trusted individual. Now, I watched a number of videos about how to put together PowerPoint presentations. I want to say that this violates what I've read, that you don't throw a bunch of words up on a slide, right? And just, but so I have violated this. So I know that it's a lot to look at. And I know it's a lot to take in because my mom was hospitalized this week in Iowa. And so I called her up and I read her this definition of moral injury to cheer her up. What I did, my mother, who is a country girl, rural Iowa, she said to me, Matthew, put the hay down where the goats can get it. I think you're the goats. But he's always had a fondness for goats. So he's had a fondness for goats, but that's a different presentation. We'll have to another time. So happily, though, my mother is doing fine and has found unlikely allies with scholars from Harvard, Duke, and Baylor and other universities, who in March 2025 published a much condensed version, a definition of moral injury. This is the definition by Tyler Vanderweel and his colleagues that put forth that says moral injury is persistent, one. That's important. We'll come back to that in a moment. But they write that moral injury doesn't need to be from a trusted individual. You don't need to have an individual involved in this. You can, but it doesn't even have to be a trusted individual. They say a person who's a victim of a random attack can suffer moral injury. Secondly, they say to suffer moral injury, morals don't even have to be transgressed. Morals don't even have to play a part in it. So they say that moral injury might arise from a natural disaster, such that your understanding of God's goodness or the goodness of the natural order is so disrupted that you are experiencing moral injury. Or they say a person may be experiencing substance abuse disorder and suffer moral injury because they're in such distress about their own character, about their own sense of goodness. They would like to think that they are good, and yet they look at their actions and maybe broken relationships or what have you, and they just don't see it, and it's causing them so much distress. So with this definition, I'll just point out one quick thing. I said persistence in that first line is important, and it is. I just want to bookmark that for a second. We're going to come back to that. But for Vanderweel and his colleagues, persistence and severity are linked together. So just kind of keep that in your mind for a moment, persistence and severity. For our purposes right now, it's enough just to highlight that the evolution of moral injury started with an act of betrayal by someone in authority. It went to a traumatic experience in which a violent act was committed or failed to protect from a violent act that transgressed deeply held moral beliefs, to persistent distress that threatens one's sense of goodness or of right and wrong. That's the evolution of moral injury. So what does moral injury look like in those who are walking around with it? So when an international team of researchers put together set out to develop the moral injury outcome scale, which is a measuring device that measures the impact of moral injury, they described 6 domains in which moral injury impacts the person, or 6 dimensions in which moral injury impacts the person. And they talk about how it impacts them with at least moderate functional impairment. And you'll hear that word functional impairment if you read a lot of moral injury literature. Functional impairment means impairment beyond what is socially or culturally the norm, right? And it may or may not include clinical treatment, counseling, medical treatment, what have you. It can range from someone seeing that something's just off about you, right? Or maybe your work performance has dipped or what have you, to something is clearly wrong with you. you're in such distress that you should see a therapist, you should see a doctor, what have you. So when we talk about functional impairment, that's the range we're talking about. So I just want to hit some of the highlights on these domains. When it comes to self-perception and moral thinking, people experiencing moral injury have been adversely affected in their sense of their own goodness. And kind of tied in with that, they have great difficulty forgiving themselves, but they're quick to condemn themselves, you know? And I don't know about you, but I think most of us have a problem anyway with our own self-talk. Right? We don't need someone to criticize us. We do enough of that in our own mind day to day. But people with moral injury, it's just on another level. And the distress associated with it is on another level as well. The social impacts of moral injury, it's not just that people want to stay home. It's that they're not only socially isolated, but when they're out with people, they're lonely in a crowd. They're socially detached from other people. When other people come up to them with friendly gestures or caring gestures, they're looking for the betrayal. They're looking for the hidden agenda, right? They're very, very standoffish. They're not going to be trusting of you. Self-harm and self-sabotaging. There is scholarship that's beginning to reveal that people who suffer from moral injury have higher rates of suicidality than those with PTSD. This is extremely concerning, obviously. Impairing moral emotions. The preeminent moral emotions of people who are suffering with moral injury are things like guilt, shame, anger, feelings of betrayal, haunting and intrusive repetitive memories and emotions, and avoidant behaviors. And also with moral injury, there's a spiritual element. People who are morally injured tend either to change their faith or lose it altogether, or change their worldview in quite a dramatic way. And so they have difficulty finding purpose in their work. They're kind of like that nurse that used to advocate for her patients and now she just wants to go home, right? But it's that in every aspect of life, trying to find meaning and purpose. I think about C.S. Lewis, who was a professor of literature. He wrote the Chronicles of Narnia as well. He married later in life. He married at 58, but his marriage only lasted 4 years. He wrote a book. It lasted 4 years because she passed away of cancer. He wrote a book later called A Grief Observed. It's kind of like his journal of his grief process. And there's a quote in there that I think is just such a great example of the spiritual element of moral distress and moral injury. How he has this expectation of going to God and a feeling of betrayal. He writes, "Where is God? Go to him when your need is desperate, when all other help is in vain. And what do you find? A door slammed in your face and the sound of bolting and double bolting on the inside." And so there's C.S. Lewis, who expected God to respond to him in one way and felt betrayed because he found that God is responding to him in a completely different and hurtful way. In a moment, I'm going to talk about the moral trauma spectrum, which just came out last year. It's a new model of moral injury. Along this spectrum is moral distress, moral injury, and moral injury disorder. So I thought it might be good to differentiate moral distress from moral injury for a moment. It's going to be on the trauma spectrum. You can read everything you want to on that chart. I just want to highlight a couple of things. With moral injury, we've talked about those definitions. With moral distress are the feelings you experience when you know the right things to do, but you are not able to do the right thing. Kind of the classic example is that physician or that nurse who's providing non-beneficial treatment, who believes that the treatment they're providing is only extending the suffering of the patient, right? But maybe because the family insists on it, maybe because the hospital they're at doesn't have a non-beneficial treatment policy, whatever it is, they can't do anything other than just continue providing that treatment that goes against their deeply held belief. And so they don't have that sense of agency that you might have in moral injury. They're just stuck. They know what the right thing to do is. They don't have a way to get to it. The second big differentiator I will bring up is that moral distress tends to be episodic. So your distress tends to go up and then it goes down. It goes up and it goes down with situations that you encounter. As situations resolve, it goes down until the next one. With moral injury, your distress goes up and it persists. It stays up. So those are the two big differentiators between moral distress and moral injury that I wanted to bring up briefly. So this was the moral trauma spectrum that came out just this past year. The authors say that the moral trauma spectrum is a means of consolidating the concepts of moral distress and moral injury, and that this is to be a starting point. That if it's going to be validated, will continue to be honed and help frame future clinical care. And so remember when I said to bookmark persistence and severity, this is where that makes a reoccurrence. So you see the horizontal axis says persistence and the vertical axis says severity. What the authors say is that what differentiates moral distress from moral injury is the persistence of symptoms. Okay? In fact, they write that moral injury is just persistent moral distress. What differentiates moral injury from moral injury disorder is the severity. So if you have high severity symptoms that last a long time, probably going to land you in the moral injury disorder category. If your symptoms are maybe not as high, but also last a long time, you might be just in the moral injury category. Okay. If you have symptoms that are high, but don't last very long, they would likely say you're in moral distress, and then it would resolve, theoretically. So this is a starting point for clinical care. On the one hand, I don't like that the lines are squishy, right? There's no algorithm that says you're on this side of the line or that side of the line. On the other hand, given that everyone has a different moral framework, it would be, I think, impossible to have an algorithm, right? Everyone experiences things differently. So we'll see where this goes in the next coming years. So let's talk numbers. How prevalent is moral injury? Well, it's difficult to say for sure, but a study done by Duke University just before the pandemic found that 23.9% of their respondents were suffering from moral injury. After the pandemic in 2022, a study from a different large academic medical center found that 40.9% of their workers were suffering from moral injury, and that 1 in 12 of them regularly experienced thoughts of self-harm. This table is a compilation of studies from 2017 to 2025 that reports the prevalence of moral injury in nurses over that 8-year period. According to care settings, so in the ICU and critical care, 40 to 55% are experiencing moral injury. In the ED, 35 to 50%. And then you have the LTAC and outpatient community care centers represented as well. One of my colleagues here mentioned that numbers are probably much higher, actually, because people don't know that they're experiencing moral injury to say that they're experiencing moral injury. So I think that's probably right. But you think about it, and think about if you dropping off your spouse or your kids or your grandparents to a unit in which 50 to 55% or more people of the staff are walking around with moral injury, who are walking around having lost meaning and purpose, walking around not trusting you, not trusting their colleagues, not trusting this organization, angry, right? And just detached. They just want to do their job and go home, right? It doesn't inspire confidence. And yet, you know, who can blame? Healthcare is hard, it's hard. And yet, there are things that can be done. So, Anna Serena, a scholar who's done a lot of work in organizational innovation and moral injury, wrote that moral injury isn't a personal or clinical outcome. It's a predictable response to sustained organizational imbalance between demand and resources. And so it's important that we have resources to meet this moral injury crisis. On February 4th of this year, Becker's Hospital Review published an article saying that every physician departure costs the healthcare organization $1.2 million in recruiting, onboarding, and productivity. And for certain specialties, it can run several $1 million depending on how long that vacancy goes. The average cost of turnover of one RN is $61,000. And a 1% change in turnover means either a savings or a loss of $289,000 per year for that healthcare organization. Right now, the Kentucky Hospital Association reports that the RN turnover rate is 16%, but it's higher in some specialties, and that Kentucky is about 4,000 RNs and LPNs short. So obviously, there's also a financial imperative to take measures to mitigate moral injury. And a great place to look is at the systemic drivers of moral injury. Organizations go to great lengths to promote their values, especially when recruiting in a competitive market. But if their values aren't integrated operationally, then values are seen as little more than buzzwords. Many organizations say they put patients first and offer compassionate care, but employees know if those values reach into the trenches. Organizational values are revealed under pressure. In the medical error that's made, in the personnel issues that everyone knows about but remains unaddressed, in the relational rupture between staff, and in 1,000 other moments throughout the day. And when organizational values are out of alignment with bedside practice, it fosters a morally injurious culture in which staff are present but disengaged. And if they feel that financial matters are drivers of clinical decisions, they'll soon find their already stretched workforce in ethical distress, disenfranchised, burned out, and quitting. But values alignment works both ways, and healthcare organizations would be wise as well to engage job seekers in conversations to reflect upon their own values and judge if they align with the organization's values. Now, this may sound naive given the nursing shortage that I just talked about, but if you're a leader, you know the cost of a bad hire. Right? A study of nurses in the UK on values congruence found that nurses saw very little difference between their personal and professional values. And it's why they'll tell you they take their work home with them. They see their work as a natural extension of who they are. And so job seekers would do well to reflect upon their beliefs and know what they absolutely need from an employer, what they can live with, and what is off limits. Because when the values of an organization are integrated into its daily operations and aligned with the employees' values, potentially morally injurious events can be opportunities to build trust and moral resilience. And when morally injurious events do happen, organizations need support systems that address root causes. A lot of healthcare organizations have EAP, and that's a great thing. But if all you're doing is handing an employee the number to EAP, the message that's received is moral injury is just part of the job, and you are the fodder. That's not true. There is a brilliant, pioneering, dare I say, landmark study out there, such study conducted by Matthew Edelman and the Center for Medical Ethics, Indiana University Health. If you read it, you'll be the 9th person. Found that the top drivers of moral distress in the ICU were conflict between patients, families, and the team, unclear goals of care, and feeling powerless. And these are manageable issues. These are things we can do things about. And ethics consultants can play an important part in helping to resolve these issues. These issues that drive moral distress, they can be resolved before they turn into moral injury. And finally, moral injury is mitigated by effective leadership. Leadership that sees and acknowledges the hardships that accompany healthcare, especially when answers aren't readily available. Because there is power in looking at another person and sincerely saying, I may not have the answers, but I am with you in this. I think Heidegger called this authentic solicitude. My presentation's complete now. That's put that in. And social isolation is further decreased when leaders provide opportunities for staff to process moral injuries in an authentic and transparent manner. Ethics rounds also foster a culture of psychological safety and enhance moral resilience. And it is so hard to overestimate the power of connecting with one person when they're suffering. Because if you've suffered and you find someone who has experienced the same suffering, they often have words that they put around it that maybe you can't and haven't been able to put around your own suffering. And they are the answer to the questions that the mystics used to ask. Who is this who speaks to me with my own voice? And of course, you'll need continual education on moral injury to keep it top of mind for staff. And continue to speak about it and normalize this so that people can come forward without feelings of guilt and shame. Fundamentally, moral injury is about loss of kinship. I've just talked to you for 30 minutes about moral injury and put up a bunch of bullet points, but bullet points, they've never convinced anybody. We are wired for connection still. You know, we are surrounded by marvels of medical science, and yet the morally injured are moved by very little of it. And if 35 to 55% of us are deeply wounded healers, strangers to our professions, our colleagues, and to parts of ourselves, then we need people who recognize moral distress in each other and come alongside each other and say, I am with you in this. We need people who come alongside clinicians who are working challenging cases and say, you feel bad because it's bad, not because you're bad. Because for all the advanced therapies, there's nothing more healing than coming alongside someone and seeing them and letting them know that you see them and that you're with them. Because healthcare is hard, but that sense of kinship makes the hard things doable. Thank you.